Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And we have a very interesting case for you here. It's of a patient who is suffering from a condition known as acute otitis media, which is a middle ear infection. So the middle ear is the space behind the eardrum. When you first examine this patient's ear, you may be easily mistaken to believe that this patient has got an outer ear infection because of all this purulent discharge that's collecting in their ear canal. However, all of this purulent discharge is actually originating from behind the patient's eardrum in their middle ear, and it's seeping and weeping through their grommet. So you may be able to see in the distance a white cylindrical object, and that is what we call a grommet. I think in the States across the pond it's called a ventilation tube. And during the course of the video I'll explain what the grommet is, why the patient has it, and I'll also try and discuss the different types of otitis media because there's different types of middle ear infections that patients can suffer from. So let's begin discussing the grommet. So the patient has got this grommet because they suffer from chronic eustachian tube obstruction. Directly behind the eardrum we have a cavity known as the middle ear cleft, and the middle ear cleft should be full of air, and the air pressure in the middle ear cleft should be equal or equivalent to the air pressure in the atmosphere, so in the ear canal. When the air pressure is at an equilibrium either side of the eardrum, that's when your eardrum is most mobile in response to sound waves, so that's when you hear the best. So it's the responsibility of a tube called the eustachian tube, which connects the middle ear cleft to the back of the nose, the nasopharynx, to equalize the air pressure. At normal resting state, the eustachian tube is actually shut, and the reason why it's shut is that it prevents upper respiratory tract infections travelling up the nose, up the eustachian tube, and infecting the middle ear. So having that tube at normal resting state shut is actually a good thing because it prevents the transfer of infection from the back of the nose into the middle ear. It also prevents you from hearing your own voice when you speak, because if that eustachian tube is permanently open, when you talk, not only is your voice being heard via your ear canal, so the voice comes out your mouth, travels via air conduction through the ear canal, hits the eardrum, and you can hear it, but it can also then travel up your nose and travel up the eustachian tube and hit and vibrate the inside of the eardrum. So you can hear your voice twice, and because the distance the sound has to travel between travelling through your ear canal and up your nose is somewhat different, you're hearing your voice at two different intervals, so you can get kind of a mismatch of your voice, a muffled effect. Now, the eustachian tube opens around 3 or 4 times a minute. So it's an involuntary action when we swallow, yawn or chew. The muscles at the back of the nose where the eustachian tube is contract, and that causes the eustachian tube to open just momentarily, but just enough for the middle ear to equalize the air pressure. So if there's too much air in the middle ear compared to the atmosphere, air will escape. If there's not enough air in the middle ear compared to the atmosphere, the air will travel up the eustachian tube to fill the middle ear space. Also, the eustachian tube has a secondary function. It acts as a drain pipe, so any fluid that can accumulate behind the eardrum, it can drain away, because we do want air behind the eardrum and not fluid. Now, this patient has got a very narrow ear, and I suspect they've got narrow orifices such as the eustachian tube, so it's a chronic problem this patient has got. So for them, their eustachian tube just doesn't open, or if it opens, it doesn't open for long enough or wide enough. And that means there's always a shortage of air in the middle ear. So whatever air there was in the middle ear cleft, it gets absorbed by the cells that line the middle ear. The cells that line the middle ear, the skin, is a mucosal skin. So the mucosal skin is similar to the skin that lines the inside of your mouth or your nose. So all the remaining air gets absorbed, and that then creates a vacuum. There's no air left in the middle ear, and your eardrum gets sucked inwards. And when all the air gets absorbed by the mucosal cells, it actually forces fluid inside the cells to leak out. It forces it out into the middle ear. So you can also get a buildup of fluid accumulating in the middle ear. That fluid typically initially is sterile fluid. It's not infected, but then if it doesn't resolve, it can become infected and purulent, a bit like what this discharge is. So almost twice a year this patient's eustachian tube gets blocked, and they've previously had a grommet. Now, what does a grommet do? Because the eustachian tube is out of action, you can think about the grommet or the ventilation tube as a bypass. air can enter the middle ear cleft via the ear canal because it can't enter via the nose up the eustachian tube. So it's a secondary route, and so the grommet allows the air to be equalised with the side of the eardrum, which then allows you to hear well. And because there's not a shortage of air in the middle ear, because it can travel through the eardrum, fluid doesn't get forced out the middle ear cells. Now, this grommet has probably been in there for a year. Normally, it falls out between 6 and 12 months, and we hope that during that time, whatever's causing the eustachian tube obstruction, especially in children, because it's quite common in children are growing up, the eustachian tube is narrow just because of their age. It also has a more horizontal orientation, so gravity doesn't really work well. As we get older, the eustachian tube widens a little bit, and it reorientates, it becomes more vertical. And when it's more vertical, any fluid that accumulates is more likely to drain out because of gravity. So in children, it's a short-term fix, and we're hoping as the child gets older that the eustachian tube no longer becomes an issue, and the grommet normally just works out and it comes out the ear naturally. Now, what's happened here, unfortunately, this patient has developed a middle ear infection, and it's an acute infection. So it's happened quite rapidly, and acute otitis media can either be of a bacterial or viral origin. And typical hallmarks with acute otitis media is inflammation. So things can be quite red. We can also call that erythemia. You get a bulging of the eardrum. Now you can see where the grommet is. To the left of it, there's some granulation tissue there, which is inflammatory tissue. And you normally experience that when there's trauma and the ears are healing. But that part of the eardrum in particular is bulging. And the giveaway sign is the purulent discharge. Now, if you have 3 episodes of acute otitis media within a space of 6 months, we typically call that recurrent acute otitis media. So this is what this patient's got. So this patient has got some sort of bacterial or viral infection in the middle ear. It may well be as a result of an upper respiratory tract infection. The eustachian tube may have opened and it might have travelled up. Now, another type of otitis media is simply called otitis media with diffusion, and that's also known as glue ear. There's other names such as serous otitis media, secretory otitis media, or non-suppurative otitis media. And that's when you have a collection of sterile fluid. So the fluid behind the eardrum is not infected. It's sterile, and it's almost of a thick amber consistency, almost like a straw-like colour, like a mucus kind of type of consistency. So when you suction it, it actually stretches. And so when you have otitis media with diffusion, there's normally no acute infection. And that can simply occur because the eustachian tube is blocked, all the air is absorbed by the middle ear cells, which forces out fluid, and that fluid is amber-like, non-infected, sterile fluid, and that's what we call otitis media with diffusion. Now, typically with that type of otitis media, there's no inflammation, there's no bulging of the eardrum. Now, if you're an adult and you have otitis media with diffusion, you do need an urgent referral to ENT just to rule out a nasopharyngeal mass that can occur. So this is a cancerous mass that can occur in the postnasal space, or the nasal pharynx, and that can block the eustachian tube. So you've got to rule that out. So if you are an adult and you have otitis media with diffusion, please do visit your GP or audiologist. They can examine your ears, perform a pressure test, a tympanometry test to see how mobile your eardrum is. And if it is otitis media with diffusion and not an acute otitis media due to a viral or bacterial infection, you will need an ENT referral. They'll place a nasal endoscope up your nose just to rule out a nasopharyngeal mass. You can also get another type of otitis media. We call that chronic suppurative otitis media. And that's when you've got chronic inflammation of the skin that lines the middle ear. And the hallmark of chronic suppurative otitis media is when you've got a perforation. So there's a hole in your eardrum and you have persistent discharge, typically for more than a fortnight. We will label that as suppurative otitis media. So I've referred the patient to the GP. They've already been prescribed oral antibiotics, but I want them to have topical non-ototoxic drops of ciprofloxacin, which can enter that space. I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.